Yes, Dipesh, we want to hear from you. Everything is okay? I am not able to see you.
He's getting connected to audio, so just wait for a few minutes and let's see. If there is any issue with the audio thing, you can leave and rejoin. That generally solve the problem, or you can remove the earphones, directly connect with the system. I think Dr. Smriti has joined by the name Smriti. Please confirm, Mr. Shivshankar. Yeah.
Dr. Smriti, I hope you have joined. Hi, ma'am. Hi. Good evening, doctor.
Please unmute Dr. Smriti. Yeah, unmute.
Hello, how are you?
All good, ma'am. How are you?
I'm okay, I'm good.
You're really doing a lot of hard work, ma'am.
Sleepy, I'm very sleepy. Anybody joined or it's?
Yes, Dr. Aseem is there, Dr. Madhulika is there, and we have the doctors also, they have joined us.
Hi, Dr. Smriti.
Dr. Madhulika, how are you?
I'm good, thank you. How are you? Sleepy, I heard.
Yes?
You said you were sleepy.
Oh, yes.
Had a busy day today.
No, yes, bit busy, not so busy, a little bit busy. And all the best for your presentation.
Thank you, thank you.
I'm hoping to learn from you today, a lot of things, a lot of new things.
Same here.
Yeah.
Hi, Smriti. Good evening. Thank you for joining us. How are you? You look. Can you hear me?
Yes, I can hear you. Can you hear me? I think audible.
Now I can.
Thank you so much, all of you, for joining you guys today. Thank you, everyone.
Thank you, Dr. Smriti, for joining us today, and we are really grateful that you find out even all our Dr. Aseem Sharma sir and Dr. Madhulika ma'am for getting this time from your busy schedule. We welcome you all, and Dr. Swati, can we start?
Yeah,
sure.
Sure. Please start, Mr. Shivshankar.
Welcome you all on today's session on hormonal skin aging. On behalf of UDerma team, Pharma State Academy, they are into learning and development and into the media partner with us today. I welcome you all, our faculties, Dr. Madhulika, Dr. Aseem, Dr. Smriti for today's session. And first, I would like to introduce our today's moderator, Dr. Aseem Sharma sir. And Dr. Aseem Sharma is a squadron leader. Dr. Aseem Sharma. Dr. Aseem Sharma is top dermatologist in practicing in Mumbai. He is an author, speaker, youth leader, military man, journalist at New Delhi Times, and the skincare expert. Dr. Aseem Sharma sir is an alumnus of the prestigious Armed Force Medical. He was an assistant professor of dermatology at Sion Hospital, and sir has retired from the Indian Air Force and has an overall of experience of more than 10 years in the field of clinical dermatology, aesthetic dermatology, lasers, vitiligo surgery, trichology in his practice. And Dr. Aseem Sharma sir is triple postgraduate in dermatology with MD and DNB, and has done the fellowship into trichology under most prestigious trichology professor of Mumbai, Dr. Rachita Durat. Thank you all faculties and delegates for joining us today. I would like to hand over the session to Honorable Sir Dr. Aseem Sharma. Thank you very much, sir.
Thank you so much, Maurya ji. Thank you for that wonderful introduction. Let's hope we can live it up by the end of today. Good evening, everyone, all friends, everybody who's come back from their busy practices or OPDs. I welcome one and all to the first day of the week and possibly the worst day of the week. Hopefully, we'll be able to spark your interest while we speak about the aging skin, the effect of hormones, and exciting research molecules that specifically target these effects, which are hormonal. Obviously, we'll talk about a lot more, but we do have an in-depth lecture on the same topic first, which is going to be followed by a practically oriented panel discussion where we would be joined by a member from across the border as well, as most of you know. I'll urge all of you at the outset to send in your questions, as this is a new molecule, a new indication, something which we have to repurpose and reinvent. So we must all come together and share experiences to back the evidence that is present. Without further ado, let's start the session. At the outset, I'm very grateful to the UDerma Laboratories team, not only in India, but Nepal and Bangladesh, and Mr. Maurya for piecing together this wonderful and interesting session. It's my honor to welcome Dr. Madhulika to the fold for the lecture. She's the director and co-founder of Skin Saga Center for Dermatology, a center that all of you know is very close to our hearts. She was formerly associated with the Wockhardt Group of Hospitals, Mumbai. She's done multiple fellowships and observerships in the fields of dermatosurgery and aesthetics, both from India and abroad. She's a gifted vitiligo surgeon, a brilliant clinician, and whenever she gets free time, a brilliant painter as well. Over to you, Madhulika. Let's get the ball rolling and please educate us on hormonal skin aging and the newest kid on the block in SkinCeuticals. Over to you.
Thank you, Aseem, for that wonderful introduction. So without wasting any more time, I'm just going to share my screen here. So I will firstly like to thank you, Dharma, for this opportunity here today, and my co-panelist, Dr. Smriti, for joining us from across the border, like Aseem said. So I would like to start by stating this wonderful quote by Dr. Howard Murad: "Aging is a fact of life, but looking your age is not." So today, through this 1 hour CME that we have planned for you, we are going to talk exclusively on aging skin. But before we get down to individual ingredients and molecules, let us first understand the basics here. Now, we all know that aging is a process of progressive decrease in the maximal functioning of all organs, and this includes the skin as well. And aging is a result of either intrinsic factors or extrinsic factors. Now, when we see the different decades of our lives, in our 20s, what the skin shows as far as aging is concerned is a little bit of dryness. By the time the person is in their 30s, the dryness has increased gradually with age spots, larger pore size, skin under the eyes becoming more and more delicate. By the time the person is in their 40s, fine lines start appearing around the eyes, the mouth, the forehead furrows appear, the skin shows visibly less elasticity and more dryness. And by the time one is in their 50s and 60s, the skin has become a little rougher, the fine lines have become what we call static, and the jaw and the eyelid may eventually start to sag and droop. And this is all, a cumulative effect of a lifetime of exposure to gravity and other elements as well. Now, like we mentioned, that the factors which cause aging can either be intrinsic factors such as genetics, cellular metabolism, hormonal influences, as well as other metabolic processes, and extrinsic factors which we are exposing our skin on a day-to-day basis is chronic light exposure or photo exposure, pollution, ionizing radiation in various forms, chemicals, toxins, and an unhealthy lifestyle, which may include smoking, alcoholism, etc. Now, what is intrinsic aging per se? This is aging which is genetically determined. It's a result of passage of time or chronological aging, so as to say. It cannot be modified, but yes, definitely there is a lot of scope here in order to reverse their effects or prevent them. And extrinsic aging, like we said, develops due to external factors, and out of which sun exposure is the most prominent one, which accounts for 80% of photoaging. Smoking, excessive alcohol consumption, poor nutrition are the other factors involved, and most of these can be definitely modified. Now, the process of skin aging, be it intrinsic or extrinsic, eventually leads to skin collagen and elastin degeneration. Moreover, there are other things here, such as water loss, sunlight exposure, free radical damage, poor nutrition like we spoke about, impaired cell renewal as we grow older, the effect of pollution, irritants, eventually causing reduction in collagen, elastin, HA. And we all already know that reactive oxygen species do play an important role as far as skin aging is concerned. Now, we all know what reactive oxygen species are. They can either be free radicals or reactive oxygen molecules. And they are generated from cellular mechanism or other extrinsic factors which we've discussed, including sun exposure. But what do these ROS do? They damage cellular structures, including the cell membranes, proteins, DNA, which eventually lead to faster aging. Now, photoaging, like we said, is one of the most important or the most culpable agent here as far as faster aging is concerned. So over a period of time, the sun's ultraviolet rays do damage certain fibers in the skin, which are known as elastin. What happens when elastin breaks down? It causes the skin to sag, stretch, and lose its ability to snap back after stretching. So while sun damage may not show when the skin is young, but later on, the cumulative effect of it will definitely be visible. Now, we've already seen the mechanisms or the factors which do cause aging, but what are the signs of aging? What is the patient going to see? Now, early signs of aging include a dry and rough skin, volume loss, dull and uneven skin tone, and age spots. Advanced signs of aging include fine lines, wrinkles, visible pores, and a sagging skin. Now, when it comes to a dry skin, how does aging play a role here? As we age, our body produces less lipids. There is improper sealing of the moisture barrier, that is your stratum corneum. There is increase in the transepidermal water loss, eventually leading to skin dehydration or dryness. What about patients who complain of dull complexion, rougher texture? Why does that happen? Ultimately, photodamaged or aging skin shows the presence of weakened blood vessels in the dermis and flattening of the dermal papillae. It eventually leads to a decrease in the surface area between the epidermis and the dermis. That means there is skin atrophy or skin thinning, leading to a decrease in the nutrient and oxygen supply, leading to a slowdown rate of cell division at the stratum basale, leading to a dull complexion and roughness of texture. Now, what about fine lines and wrinkles? As we all know, as the age increases, collagen production decreases, collagen degradation increases, which leads to a decrease in the total collagen of the skin, leading to the appearance of fine lines and wrinkles. Now, in photoaged skin, this is like a basic summary here. Decrease in lipid synthesis leading to dryness, decrease in the multiple of dermal papilla and stratum basale leading to a dull complexion and rougher texture, and decrease in fibroblast, collagen and elastin synthesis leading to fine lines, wrinkles, and a loss of tone or firmness of the skin. So most anti-aging treatments will either aim to prevent, repair, or protect. And here we are talking about topical anti-aging treatments. So how do we prevent them? Prevention will include molecules which work as antioxidants, which offer some kind of sun protection or improve the skin hydration. How do we repair? Again, antioxidants play a very important role here, along with retinoids and topical hyaluronic acid or topical fillers. And protection is offered again by antioxidants. We all know they are skin protective, along with moisturizers and sunscreens. So this is just a comparison of the different signs of aging. If taken care or treatment taken at the proper time with the right kind of molecules, it is very much possible to improve and reverse these changes. Now, since we all know about the invasive methods, light-based methods, laser-based methods, let us look at the ingredients which will help us in the topical form to either prevent, repair, and correct the signs of aging. So firstly, let's talk about, just a second. Yeah, so let us talk about retinol. Now, retinol, as we all know, we do use routinely and regularly in our practice. It's topical vitamin A. It does have the potency to reduce fine lines and wrinkles, considered as the gold standard as far as topical anti-aging modalities are concerned. it is readily absorbed from the surface of the skin when it is applied topically. And we all eventually through research have come to know that smaller molecules of retinol go deeper into the skin. That is, it does have the potential to reach the dermis as well. So what are the benefits of retinol? It exfoliates the skin, it makes the skin bright, does prevent acne, does reduce pigmentation and an uneven skin tone, and obviously the anti-aging benefits. Now, how does retinol act on the skin? Retinol binds to the retinoid receptors on the skin, enhancing the cell turnover rate, and it also stimulates the production of elastin and collagen, which we all know that in aging skin, there is a decrease of. It thickens the deeper layers of the skin and enhances the skin's ability to retain more water, so there is lesser transepidermal water loss. It improves fine lines and wrinkles and reflects a youthful glowing skin. Also, it thins out the topmost cornified epithelial layer of the skin and thus leads to an improvement in the texture and the tone. So how does it function? It also functions by normalizing the functions of the oil glands and their follicles, controls sebum production, as we all know. It also softens the fine lines and spots in targeted areas, or if you're using it all over the face, that also works. It stimulates the production of new blood vessels on the skin, reducing skin pigmentation, and it also alters the behavior of aged cells and makes them appear more youthful. Now we are talking about a special ingredient here, that is retinol 3A+. This is a highly concentrated 3-retinol system in an encapsulated form with an advanced 3-stage delivery technology. Now this is something very unique and very interesting. So the 3-retinol system, that is this newer delivery technology, releases retinol in 3 phases. One is the continuous retinol release, which happens. Second is the immediate retinol release, which happens. And third is a delayed retinol delivery. Now, because the delivery is happening in a very staged and phased out manner, there is progressive retinization of the skin without the typical or the commonly occurring irritation, which we all associate with topical retinoids. Now, another new ingredient that we are looking at here is called as Aquaxyl. It improves the skin moisturization by preventing water loss. So what it is offering is a 3D concept of hydration for circulation of moisture throughout all the layers of the skin, and even boosts the production of hyaluronic acid. The next ingredient to look at is ubiquinone. Now we all know ubiquinone or coenzyme Q10 is a part of a lot of prescriptions which are for anti-aging. It's basically a coenzyme because it needs other enzymes to function properly. So what does coenzyme Q10 do? It is vital in energy production in cells. So it energizes the cell activity, it reduces sun damage, it evens out skin tone, stimulates collagen and elastin production, replenishes the skin cells, and also reduces the appearance of wrinkles and fine lines. Then the other ingredient that we talk about, as we all know, is hyaluronic acid. No anti-aging treatment could be complete without mentioning hyaluronic acid. However, here we are talking about topically applied HA. Now, topically applied, this is a special formulation which contains hyaluronic acid in different forms with varying KDA. Now, hyaluronic acid can have a good effect in the various layers, trying to improve the texture of the skin from the stratum corneum till the dermis. So we are going to talk about a few other derivatives of hyaluronic acid. One is the hyaluronic acid cross-polymer. This is a unique cross-linked non-animal form of HA which delivers water and water-soluble actives throughout its non-equilibrium gel structure, helping to maintain the water content with repeated use. Now, the complex delivery of water-bound content throughout this system will allow smaller size technologies to remain effective topically, even in the presence of high molecular weight HA that usually impairs absorption. Now, this is a unique factor here. With very low molecular weight HA, HA complex is near impossible molecular weight for lasting hydration, with continued use in a form never before associated with hyaluronic acid. Then there is hydrolyzed or low molecular weight HA complex, which offers lasting comfort and hydration for the skin with repeat use. Then the other form of HA which is being used is sodium hyaluronate. which is actually a form of salt which is derived from HA. Again, it has a smaller molecular weight, and hence since the molecule is much smaller than your typical traditional HA, when used topically, it has the ability to penetrate the skin much deeper and more effectively. So I'm not going to read through this technical aspects here. However, to summarize, the topical HA should be anywhere between 8,000 to 1 lakh Daltons. That is the sweet spot according to a lot of research and studies which have been done. Anything more than this weight will not do much good for the skin, and anything lower might cause inflammation. So this is the sweet spot that is between 80,000 to 1 lakh kilodaltons, where our HA molecular weight has to be focused at. Now, another ingredient here is matrixyl, which is also called as palmitoyl pentapeptide. It is a new molecule which stimulates the growth of new collagen, elastin, and HA, which aids in refilling wrinkles naturally from within the skin. So what are the indications of matrixyl? Early and advanced photodamaged skin, where it targets dry skin, a dull complexion, rough texture, fine lines and wrinkles, and loss of firmness as well. So eventually, from the stratum corneum till the dermis, it is locking in water, it is making the skin softer, as well as providing hydration, since it is a small molecule HA penetrating deep. So again, the benefits here, like we've said, is multi-layer hydration being the focus. It protects and replenishes the outer layer of the skin as well, improves the soft tissue function, and promotes a smooth and more elastic skin, and can be used in any skin type. Coming to our next molecule or next ingredient, arginine. Now, we've all been using arginine mainly as an anti-pigmentation molecule. However, it does have its anti-aging effects also. And it's useful in reducing the appearance of fine lines and wrinkles. It keeps the skin firm, plump, and smooth, and also helps in dehydrated skin by restoring moisture. Now, what is the USP of this particular preparation? The HA, the triple power HA, has a multi-layered hydration action. It rejuvenates, refreshes, and redefines. The matrixyl component is definitely a collagen booster, and it optimizes the result of other treatment approaches which you may be using in the patient, be it your chemical peels, laser therapy, microdermabrasion, or any prescription skincare products which may cause a little bit of irritation to the skin, such as hydroquinone or other stronger retinoids. Now, the next ingredient, which we all are so super familiar with, is vitamin C or L-ascorbic acid. We all know it's a water-soluble vitamin, and it must be obtained through diet to get it in its natural form. However, there are a lot of new preparations now which deliver pure vitamin C. It fights excellently against free radicals. It is an antioxidant, and that is the reason why it is part of most of our prescriptions. It can reduce damage to the cells, leading to cellular aging, which lead to fine lines, wrinkles, and dullness. It also helps remove these free radicals before they cause any cellular damage. So we all know the role and how antioxidants act in preventing free radical damage. They steal the electrons from the molecules which make up our cells and help by donating free electrons and thus preventing cell damage. So vitamin C does boost a lot of collagen production. It also helps the body keep your skin firm, gives it elasticity, prevents sagging that can occur with age if used consistently, also keeps the skin hydrated and supple. So we all know that topically absorbed ascorbic acid, if it is in the pure form, is taken up by the keratinocytes, eventually picked up by the blood vessels, and it gets circulated back into the keratinocyte. So this is only possible with pure vitamin C and not the derivatives or other available preparations in the market. It also acts as a natural sunscreen. It slows down the damage caused by sun exposure. We all know that. And helps delay the signs of aging. It reduces the appearance of marks and scars as well by production of collagen. It is suitable for all skin types due to its adaptive property. It can be used on a long-term basis without experiencing any adverse reactions. And it does fade hyperpigmentation as well. It does contain antioxidants, helping it inhibit melanin synthesis, thus resulting in reduction in pigmentation. The next molecule here is sodium hyaluronate. We did talk about it when we were discussing hyaluronic acid. It is a salt form of HA, and it holds 1,000 times its weight in water, deeply quenching the skin with vital hydration. It is a small molecular weight size than HA and is hence able to move and penetrate through the deeper layers of the skin, making it a very powerful humectant. It does attract and retain water, drawing moisture from the available atmosphere into the skin, making it firm and a supple complexion. So this is how it acts. We're not going to go into that. Now, sodium hyaluronate does moisturize the skin when it is applied topically. It reduces dryness and flaking by improving the skin hydration. And compared to high molecular weight HA, it provides a much higher or much greater hydrating effect. So this is a comparison of the large molecular weight hyaluronic acid versus the small molecular weight hyaluronic acid, which has the tendency or the potential to go up to the deep dermis or deeper. Now it functions, we've already spoken about the functions, how it increases hydration, eventually leading to the improvement in skin texture. We come to our next molecule, that is resveratrol. Now you must have seen resveratrol in quite a lot of recent preparations. It is a part of a group of compounds called as polyphenols, which have antioxidant properties. Commonly, naturally, it is available in the skin of red grapes, and also found in peanuts, red wine, berries, and other foods. So how does it act in aging skin? It has a twofold effect. It neutralizes free radicals by its antioxidant action. Plus, it boosts the antioxidant levels of the skin so that it can repair and better itself. It can defend better and repair itself, sorry. So there was one study which found that topically applying resveratrol significantly improved fine lines, wrinkles, and elasticity in 12 weeks. So a lot of research has been done around this particular molecule. It does look promising. However, it is only through our experience that we will know better. So it also does protect against UV damage, reducing the appearance of sunspots. It has a role in minimizing skin inflammation and redness. So it does have a role even outside of aging, can be used in a lot of other indications. It helps, it does have hydrating effects, so can be used in conditions like eczema and psoriasis. There are reports which state that, and improvement in the texture of skin as well. So our next molecule to discuss is pentavitin. Pentavitin again is a potent hydrator which provides instant hydration for up to 72 hours. It creates a moisture barrier on the skin and binds deep with the layers of the skin, holding on tight for up to 72 hours, thus giving it a long-lasting protection against damaging effects of environmental factors, to name cold weather, pollution, heat, etc. It helps maintain the skin's natural moisture barrier while smoothing and plumping the skin over time. And because the skin is so deeply hydrated after application, the fine lines do appear to be reduced as well. It makes a great moisturizer for dry skin, and it cannot be washed away since it's locked into the layers of the skin. So it is in a way called as the waterproof moisturizer. We've already spoken about coenzyme Q10. So coming to this different topic now about hormonal aging. Now we all know hormones are natural chemicals produced in one location, released into the bloodstream, and used by other target organs. And the hormones control the target organs, so as to speak. And as we age, some target tissues become less sensitive to their controlling hormone, giving rise to various changes which we may see on the skin and otherwise as well. So the amount of hormones produced also may change as aging progresses. Hormones eventually or gradually are broken down much more slowly than when we are younger. And especially when it comes to women, they have lower levels of estradiol and other estrogen-based hormones after menopause. So what effect does estrogen deficiency have on skin, especially around the perimenopausal or menopausal age? It causes atrophic skin changes. It accelerates skin aging. Estrogen insufficiency decreases the defense against oxidative stress. Skin becomes thinner with lesser collagen, decreased elasticity, increased wrinkling, increased dryness, and reduced vascularity as well. So its protective function becomes compromised. And as we all know, aging is associated with impaired wound healing, with hair loss, with pigmentary changes which happen. So hence, estrogen is a very important hormone which is necessary to maintain the aminoglycans and HA in the skin. Its deficiency does lead to a lot of dryness and scaly skin. And we all know that topical estrogen has been around for a long time. However, its impact or its role in anti-aging has not been explored, but it does have a definitive role here. So I'm going to talk about another molecule here called Uplavity or acetyl tetrapeptide 2, which works by tightening our dermal elastin and collagen fibers. It revamps dermal structure for a tighter, more lifted appearance. And there are clinical studies which have shown that a 2% solution used twice a day can improve the tightness of the skin. So the tone of the skin, the firmness of the skin can be improved with acetyl tetrapeptide 2. So it also helps fight the sagginess by enhancing the key elements, which eventually lead to the assembly of elastin and several collagens that we know are depleted or decreased as we age. So this it does by overexpressing genes which are involved in cellular adhesion. What is the mechanism of action? We've just seen that. And it also helps increase the synthesis of elastin and collagen. So it helps reduce their degradation and improves the production. It allows the skin to return. So the elasticity of the skin, which is lost as we age, this particular molecule, that is the Uplavity peptide, allows the skin to return to its normal shape after stretching or contracting. And it allows the layer beneath the skin, that is the dermis, to become significantly more structured and more firm. Another molecule in this category where it can be used as an anti-aging molecule in people who are perimenopausal or above the age of 45, so as to say, is genistein. Now, genistein is a soy-derived isoflavone and a phytoestrogen, that is a plant-based estrogen, which is extracted from soybean. It has a structure which is very, very similar to estrogen, and thus it works to kind of balance the reduction in estrogen which happens with age. It resists skin aging by improving the skin moisture levels. It also does stimulate the production of collagen, elastin, and HA. This is something special which genistein does, that it prevents MMPs, that is matrix metalloproteinases, from destroying collagen. So it blocks MMPs. It inhibits protein kinase and MMP kinase, and thus it modulates the cell differentiation and cell growth as well. Plus, in addition to all of this, it is also a very potent antioxidant. So where will you position this particular molecule, which is a topical form of estrogen? Basically, in premenopausal, perimenopausal, and postmenopausal women above the age of 35, who have a higher chance of estrogen deficiency, which may result in a saggy, wrinkled, and dry skin. The goal here is to treat the root cause by acting as an endoestrogen, thereby lifting, firming, and hydrating the menopausal skin. And the special part of this molecule is that it treats the root cause of menopausal or hormonal aging. And there is this particular combination or a product that we are going to eventually talk about, which is a power pack combination of all these three new molecules that we just heard about. That is genistein, Uplavity, and the low molecular weight hyaluronic acid. So to conclude, just to summarize what we have discussed here, there is early aging and advanced aging, and the kind of molecules that we have discussed here are present in these particular formulations, where you have a pure form of vitamin C in the form of UHC. We have a topical HA with low molecular weight hyaluronic acid to give you a 3-tiered or a deeper penetration and deeper hydration in Pilaron HA. For advanced aging, where we are looking at a topical retinoid, which has to be a part of our prescriptions when it comes to retinoids, as Retinex. And when we are talking about hormonal aging or estrogen based topical formulations, they are coming up with ULIF. So I hope this was informative for all of you all here, and I look forward to the panel discussion by Dr. Aseem. Thank you.
Thank you, Madhulika. I think that was a very, very lucid talk. I congratulate you for the same. You've really set the ball rolling for today. You spoke about retinols, vitamin C, hyaluronic acid, moisturizers, sunscreens, and a brand new molecule with topical estrogen and additives. I will be coming to that in a short while. So now that you set the ball rolling, we also have an international faculty and a very dear friend amongst us. Dr. Smriti has already been introduced by Madhulika, but I share a personal relationship with her, so I'm going to introduce her separately. So Smriti is a certified dermatologist at the Kathmandu University and Dhulikhel hospitals. She completed her MD from the same university in 2014. She's a mother of two beautiful kids and the wife of a pediatrician, a very successful one who himself was in Bombay a few weeks ago. We also share a common first name amongst other things. Professionally, she pursued her passion for aesthetics and got trained in China in 2017. Her favorite current procedure is fat grafting, but both she, me, and Dr. Madhulika, we share a common interest in PRP as well, if you've heard us talk at other forums. She's also learned blepharoplasty and liposuction while in China. She's received a full scholarship to attend the STI HIV course in the University of Washington in Seattle 2015. She's won multiple awards. She has multiple fellowships under the belt. Wonderful hand, a wonderful person, and a great intellectual. I welcome you, Dr. Smriti, to this panel discussion. And Madhulika's already been introduced, so we will quickly begin.
Yes, thank you so much, Dr. Aseem, for such an elaborate introduction.
You're most welcome. The pleasure is mine. So once again, I'll request the audience to send in questions. See, this is a new molecule, something that even we have limited experience about. We're mostly going to talk about studies, literature, evidence, why it should work and what patients we should use it. But we do have to come together and try to position this molecule because I think we do have a winner here. So just give me 1 minute. Is my screen visible to everyone?
Yes.
Yes.
Great. So let's talk about the SkinCeutical cocktail in anti-aging. I'm not going to talk about procedures, so I'll urge attendees to not send in questions about procedures. We will talk only about topicals and the glorious world of cosmeceuticals or SkinCeuticals. So there's a famous quote by Jimmy Buffett: "Wrinkles only go where smiles have been." Sounds lovely on paper, but ask those men and women who've had wrinkles in their early 30s and they'll tell you how much they disagree with this. So our learning objectives today, deciphering the wonderful world of cosmeceuticals, anti-aging modes and methods, and positioning topical estrogen in the anti-aging basket. So I found this amazing article which talks about the types of aging. Now there is chronological aging and genetic aging, which is beyond our control. Environmental aging, we can or cannot, maybe not in today's day and age, but maybe 2 or 3 decades ago, we could control that as well. Social aging, obviously we're all kids at heart, so let's skip that. Hormonal aging is something we're going to talk about, and psychological aging. Our main focus today, though, is going to be hormonal aging, as Madhulika has already told you before. So my first question is going to come to Dr. Smriti. I'm going to bring you into the fold. Is a skincare routine mandatory? And before I ask you this, we are now aware of day routines and night routines, thousands of cosmeceuticals, actives, and so many things available in the market. But is a skincare routine really mandatory?
Thank you for the question. I think skincare routine, is definitely mandatory. I'm sure everybody would agree with me on this, but I don't really think everybody should be using each and every product that comes to the market, because there are so many products and it is so confusing. There are so many things, and many things depend on your skin type, as your skin's reactivity, weather, season, and many other things. For example, as we see here, toners till now, as far as I know, is not a mandatory step in the skincare routine, although it does help. The basic essence of toners have changed from the past now. So there are no alcohol anymore, but still the role of toners are variable, and I see it more useful in people with wide pores and people with very oily skin. They, I think, benefit a little bit more than those with drier skin. But then again, the constituent or the ingredient of the toner would change that kind of that thing as well. And besides toner, about eye cream, there are newer evidences that are showing that the eye cream separately does help to an extent. But again, I think eye cream can be reserved to people who are on a bit older age group, maybe around after 30, since there is no specific guidelines about eye creams yet. So in my opinion, and especially recently I saw one post on American Academy of Dermatology that talked about rosacea, and I see a large number of people having rosacea, redness, sensitivity, and lots of melasma that is coming out as a pandemic. Even in a country like Nepal, Kathmandu is not a very, like, it's not a very hot place, but still people are having melasma, and every other person is having melasma. So I do believe that people with melasma, people with rosacea, they do need to be quite reserved about what they can use and they should use. And likewise, it is best, I think, at least for once, for patients to visit the doctor and then have their skin checked, have their skin analysis done, and then only decide what things to use, what not. Thank you.
So I think that's a great answer by you. Thank you for being very honest about that. I myself do not believe in toners unless I want to supply a very particular active and want to reduce the number of things that the patient is applying. But otherwise, yes, I do agree with you. Toners are more refined now. We have vitamin C toners, we have azelaic acid toners, and the world in a bottle of toners, but we have better molecules to use and better formulations to use. Face oils are another disturbing trend that we have because most of us from the Indian subcontinent have combination to oily skin. So for us, even the mildest of facial oils cannot, if not used properly, if used as an additional moisturizer, can actually wreak havoc on the skin. So that's something which I'm a little very vocal about actually on my own platforms as such. Eye creams, yes, I agree with you. Maybe except for the ones that contain vitamin K and retinol, which can be a little irritating to the eye. The other ones don't really work. Again, coming back to the Indian subcontinent, since we all share common, Aryan genes at least, or a race at least, we all have hollow under eyes. So if the structural component is not taken care of, just applying an under eye cream is not going to help. So for all the delegates who are here for periorbital melanosis, it's beyond today's topic, but do assess your patient properly before you start prescribing treatments for that. Madhulika, skincare routine mandatory, not mandatory?
Of course, mandatory. However, I don't believe in this 7-step, 8-step, 10-step routines that, is the current fad these days.
True.
So I believe in starting simple, with a simple cleanser, moisturizer, sunscreen, and a night cream routine. See how the patient complies with them, assess the patient's compliance at follow-up. If they have been regular, most probably, then I'll probably add something extra in the form of a eye cream or extra topical hyaluronic acid. But if it is somebody who's not followed the simple 4 steps properly, there's no point complicating the whole prescription with a 10-step procedure, right? So yeah, every patient is going to be different. There will be people who will be following your prescription to a T. So that is where you can probably keep adding actives as and when needed, but you don't really start off with a complicated regime, because people 10 out of 20 people will actually get fed up and not use any of them properly. So yeah, keep it simple.
Agreed. Keep it simple, silly, and let's leave the 10-step Korean glass routine to the Koreans themselves. Great answer. I will come back to the basics of a skincare routine later, but Dr. Smriti, if I can bring you back into the fold, what is the perfect age to start? And I think a lot of younger patients coming in who come through Instagram especially, they are asking us these questions day in and day out. Am I the correct age to start anti-aging? So what is your answer when a patient asks you very innocently, am I old enough to start anti-aging?
Thank you. I think anti-aging, the word in itself has different meanings in different age groups, in my opinion. Like somebody who's in their 20s, I would just stick to simple basic things like vitamin C, sunscreen. And as we know that the collagen depletion can start as early as 16. And since people faster, from what I see, like my own daughter, she's just 10 or 11 and she's already started her period. So people are maturing faster. So that does mean they will be hormones a bit faster, and I do think that the anti-aging might switch or might shift a little to a younger age. Otherwise, normally in their 20s, I just tell that they can get away with using the steps that Dr. Madhulika just said, the basic 4 steps. If they don't have acne, I don't give retinol. If they do have acne, we can use retinol at that age group as well. Otherwise, somebody who develops any onset of fine lines, I ask them to start anti-aging treatments as such, not skincare, but treatment as such only when they see any evidence of fine lines. Otherwise, anti-aging skincare can be started in their 20s, I believe.
Good. I think that's a great answer. And you also mentioned, keep it very, very simple, like Madhulika did, a moisturizer, a sunscreen, maybe a vitamin C serum, and that's probably just about it. to begin with? I think I'm very, very happy with the answer. Madhulika, do you agree, disagree? Anything else you tell your patients?
I totally agree with what Dr. Smriti just mentioned. So yeah, I have nothing more to add to that. We are aging since the time we are born, technically. So there's no right answer to this question. And, it can be as early as in their 20s. But, it all depends on what the patient's concern is at that particular age group. And, probably it could be acne or a oily skin rather than anti-aging. So it's ultimately up to us how we try and, introduce or include some of the anti-aging molecules at that point as well, which would be kind of cross-productive with respect to the original complaint that they've come with.
Great answer, and thank you for holding that adage true, that age is actually just a number. It's just about how much that number means to you at that point in time. So the 20s we've discussed. Smriti, what about patients in their 30s? Let's assume a 31-year-old male patient walks into your clinic demanding a skincare routine. Would your would the actives that you give change in that situation?
Usually in men in our subcontinent, I don't start with too many things because men are not used to use many products at the same time. So I usually start with a budget friendly, simple product at first. And then if that person is interested and if somebody is committed to using products, then I would add on a retinol in their age group, in somebody in their 30s. And rarely, in very uncommon scenario, even men can have interest in collagen peptides. They can have interest in other molecules, oral forms of anti-aging products as well. For example, oral sunscreens or oral vitamins and oral forms of antioxidants. So in those scenarios, I do add antioxidants along with the products that I've said in the past in their skincare routine in people in their 30s.
Great answer. So the only thing that changes is a retinol, and yes, the skincare routine that men have is quite alarming, except for dermatologists. I think as dermats, then we become a little more privy to skincare routines. But coming back to the topic, Madhulika, 30s, what changes for you?
So probably I will start using or introducing retinol at this point. And if it is a male patient with more, sebaceous activity or seborrhea, so to speak, so yeah, that is one thing which I would add in a male patient in their 30s, because that's the right time to introduce a retinol, as I feel. If you're in your 20s, you start with vitamin C. And if you're in your 30s, I think you can start with your retinols.
So that's well summed up, I think. So a CMS routine is the basic, like all of you mentioned, cleansing, moisturizing, sunscreen. It used to be CTM, thanks to Instagram, but we've changed that routine now. It's CMS. And over and above that, the active which you would want in your 20s is vitamin C. And the active which you want to use in your 30s is retinol. Madhulika, can you continue with the 40s?
So again, retinol will be an important molecule here. We can kind of start a hyaluronic acid topically here as well to kind of, hydrate the skin, the cleanser, the sunscreen, moisturizing. That remains the same, but, hyaluronic acid is also known for its moisturizing properties. So I may actually substitute my moisturizer with a HA-based preparation or a serum as well.
Okay, so hyaluronic acid changes because yes, the skin does start visibly sagging then. Fine lines become not so fine at that time. Smriti, what about you? 40s?
Yes, I would also like to add hyaluronic acid. And I've read few research on peptides, different kinds of peptides, including the one that we have talked about today. So the studies on peptides seem quite promising. For example, arginine or even genistein, these seem to be working quite well if they have a good vehicle. If they are used through a good vehicle, they work quite well. So I would add peptide. In fact, even I'm using a kind of a peptide right now. And I do think there is some benefit to peptides also in our 40s, especially because it also helps. What I found interesting was that it helps in strengthening the dermoepidermal junction. So what happens is in our 40s, the epidermis is flattened, dermoepidermal junction gets thinned out, and then the vascular reactivity starts to appear. They start to become very reactive. The erythema or the minimum erythema dose of our skin starts to reduce. So because of all that, I would add on an oral sunscreen, for example, polypodium leukotomus, if it's available. And I would also add on a peptide serum so that it would strengthen the skin barrier. Because from what I've understood is everything starts by weakening of the skin barrier. Most of the diseases start with weakening of skin barriers. So I'd like to reinforce the skin barrier in our 40s. That's very important. And I'd like to tell my patients to switch to gentler products. I'd ask them to refrain from using too many things and doing harsh scrubs, going to sauna and all that, and rather stick to gentle skincare routine, which they can consistently, religiously follow.
I think that's a great point by you. So in the 40s, you would, prefer hydration and gentler procedures, gentler actives rather than, stimulating too much or causing more damage than good. Speaking of damage, obviously the jade rollers and the gua sha stones and everything else that has to be thrown out of the window. I think we do need to, probably prophesize that more because there's not enough information there. People still feel that, a good lymphatic massage is much better than a microneedling radiofrequency session, but obviously we'll change that with years to come. Come the 50s, Madhulika, is 50 the right age to embrace your age? Do you send patients back with nothing at all? Or do we have products or do we have good skincare routines which we can give to patients who are above 50?
So in addition to whatever we discussed for the 40s, right, the new entrant here, that is your topical estrogen, will be beneficial from this age onwards, right? So that is going to try and prevent a lot of hormonal associated skin changes, which women after their menopause do kind of suffer, or things just try and, exacerbate after that particular event has progressed. So yes, I think addition of a topical estrogen here at this juncture would benefit and prevent a lot of these extrinsic skin changes which may happen.
Great. So topical estrogen comes into the fold. Smriti, what about you?
Yes, I think as we age, the one of the things that our body or skin loses the ability to cope with is inflammation. That there is even a small amount of pro-oxidative damage or even a small amount of stress cannot be combated as easily as we can do at a younger age. So definitely antioxidants, lots of different kinds of antioxidants. There are studies that have talked about combination of antioxidants rather than using just one, because each one has benefit, but there are many issues of the penetration, delivery, vehicle, the size of the molecules. So because of that, I'd like to ask patients to use different combination of antioxidants. For example, somebody has oily skin, that person can go start niacinamide if they haven't already, and they can niacinamide has a role of reducing the water loss that retinol causes. Since in our 50s, what I see frequently, the challenge that I see among women who have never used retinol in the past and they're suddenly starting retinol in their 50s, they do not know how to manage this because of the dryness that it causes. So in order to combat that dryness, you can use niacinamide, or we can use, as Dr. Madhulika said, we can use hyaluronic acid, different forms of hyaluronic acid in combination with retinol. And then again, I'd also ask people, besides just talking about, I'd ask people, okay. Yeah, okay.
Yes, please go on. I think, yes.
Ask women in their 50s to be mobile, to move about. And there is a great evidence of gut, skin, brain axis. There are many things that's come about gut, skin, and brain axis. So I'd ask people to have healthy diet, probiotics, and even, I don't know, there's mixed reviews of collagen supplements, but I do think the good ones, the good quality collagen supplement does help to an extent in improving the skin elasticity, hydration, and wrinkle improvement, along with the peptides that we have discussed today.
I fully agree with you. Thank you for bringing collagen into the fold. Even I was quite, I think I wasn't against it to speak personally, but there were never good formulations available in the market. But bioactive collagen peptides now have a lot of research in them and a lot of people are using it. Maybe not purely for anti-aging, but for lots of other benefits as well. So that's something which definitely can be given a try. And you did bring out a very, very important point, which I've liked throughout, that, hydration has to go along with repair. You can't repair without hydration. So hydration has to form a key point in your skincare routine, the older the patient gets. Madhulika, googly for you, since you love cricket, 60s.
So
I have no answer for this. That's why I'm asking you this.
So when a patient in their 60s does come, I go back to the 20s, or what we try and prescribe when a patient in their 20s come, trying to keep it simple, right? Because by this age they are probably plagued by other disorders or other comorbidities as well, and then skin doesn't really take the forefront. However, they do want to end up using something to maintain their skin. That's all they want. They're not expecting to reverse those deep wrinkles or deep folds which may have set in by the time they're in their 60s. So again, sticking to a cleanser, probably a HA, and a simple sunscreen is what I would prescribe in their 60s.
Great answer. Going back, I think reinventing the wheel, and when life comes a full circle, start from where you finished. Okay. Smriti, what about you? 60s.
Yes, I do agree with Dr. Madhulika. It has to be simple, I think, to start with, because one more thing that what usually happens is as we age, the skin turnover starts to get really, really slow. That makes the skin dull and coarse. So I would also ask them to very carefully exfoliate, not more than once a month probably, but do exfoliate so that the newer or the skin renewal process is also helped to an extent, besides other things that they already do.
I think great answers from the both of you. So we've seen what to do in the 20s, 30s, 40s, 50s, and even the sixth decade of life. So if topicals do actually work, then I think we've got a winner. So Madhulika, you spoke about hyaluronic acid. Is it as good as it gets? A few years back, a lot of negative reviews on hyaluronic acid, just another moisturizer, just a humectant. It doesn't stay on the skin too long. It doesn't even penetrate the skin as much as it's supposed to. So can we actually call it a topical filler? Okay, we'll start with this. What about penetration of hyaluronic acid, and can we actually call it a topical filler? I'm going to ask Smriti this, since Madhulika has already spoken.
I think it again depends on the brand. It depends on the molecule, the brand, the weight of the hyaluronic acid, and how well formulated it is. There are many brands in the context of Nepal which actually do not work. So I think it's totally brand dependent.
Agreed. The more R&D a brand puts into it, and the more research backed, the better the formulation is. So many things do matter when it comes to hyaluronic acid. I agree with you. Madhulika, you mentioned something about a sweet spot. 800 to 1000 kilodaltons. Can you tell the audience once again what you were talking about?
So there are a lot of hyaluronic acid preparations in the market, and as what I spoke in my presentation, the higher molecular weight ones do just stay on the surface of the skin and don't really penetrate where they should. So with the advent, or with as research has progressed more, the low molecular weight hyaluronic acid has come into the picture now, with newer formulations which probably penetrate much better, which get hooked onto the different layers of the skin, making sure there is a uniform penetration and hydration happening across all levels. So yes, if so much research has gone into developing a low molecular weight hyaluronic acid which claims to actually hydrate the skin much more than something which is a higher molecular weight one which just rests on the surface, I think we have a winner. As far as calling it a filler, I think probably the nomenclature there has to kind of be more inclusive of its hydrating properties. I think that is the only reason why it would be termed as a topical filler.
Great answer. So multi-molecular weight is the way forward. We have lots of brands now for that. So that's something where a lot of research has gone in. And do agree with you to some extent. Ascorbic acid plus friends. And when I say friends, I mean pure ascorbic acid, which all of us know is L-ascorbic acid, and friends, your magnesium derivatives, your ascorbile derivatives, your phosphates, vitamin C derivatives, Smriti, or pure ascorbic acid for you? Are you old school, or do you believe in the newer ones?
I think there is more data on the pure one, the L-ascorbic acid, which is quite readily absorbable, and its absorption is also penetrated by its friends, enhanced by vitamin E, zinc, ferulic acid, and all that. So I think L-ascorbic acid all the way, but then there are certain subset of patients who react quite strongly to L-ascorbic acid. So in those people, yes, ethyl ascorbic acid and other newer ascorbic acid can be tried.
So that's a very valid point. Anybody? Sorry, please, after you, Smriti. Please.
Sorry, no, that's it. Thank you.
So what I was trying to say was that L-ascorbic acid had earned a bad name, especially in people with oily and sensitive skin. That was a skin type where you would absolutely avoid L-ascorbic acid like the plague when we had only the original brand. But now with the derivatives in the foray, they're much better tolerable. And something like a 10% or a 15% or even 20-25% are quite easily tolerated by the skin as opposed to pure ascorbic acid. But I think choose your vitamin C's wisely. The whole game these days is choosing your weapons wisely. There are thousands of weapons, but knowing which one to give to which patient and which skin type, it all boils down to that. Madhulika, what roles does vitamin C fulfill for you in your practice?
So in my practice, the reason why I would prescribe ascorbic acid would be for its antioxidant properties. It kind of enhances the effect of sunscreens as well. So that's another add-on bonus. And as far as patients wanting a good glow or brightness on their faces, I think ascorbic acid does have a role in pigmentation. It's not a strong depigmenting agent, but overall, say the glow on the face, I think that is where ascorbic acid would score over the others.
It's good for improving uneven skin tone. In fact,
right.
pure L-ascorbic acid is known to be a good collagen inducer as well, but I can't say the same for the derivatives. And we don't normally rely on that single quality of vitamin C. I mean, we have other collagen boosters which are much more potent.
Yes, can I ask one question here?
Yes, please. Of course you can.
Yes, because initially it was said that the vitamin C should be used in the evening because it is not stable. It's an unstable compound. It just evaporates and it's unstable and it is destabilized by sunlight. So we started using it at night. And then later it was found that the vitamin C is more preventive than of reparative capacity. The vitamin C is more preventive rather than reparative, so it should be used in the morning since there is more prevention. But lately I also see certain kind of vitamin C that newer brands have introduced that they are using it at night, and they call it specifically vitamin C to be used at night. So I'm a bit confused about that end. So what makes a particular vitamin C to be used at night?
So I think the pure vitamin C's are the ones which used to be used at night because of the irritation potential. And if you look at the old ones, the white or yellowish serum would turn brown very soon, which means it's oxidized and you can't use it after that. Whereas if you look at the newer derivatives, they rarely change color. I mean, most of our bathrooms are well lit these days. We have so much radiation and so much visible light around, but nothing seems to happen to, even open. Even if you leave a vitamin C's open in your bathrooms or drawers, I don't think anything happens to the derivatives. But with pure, I would be a little cautious. I have had patients who have reacted very badly to pure L-ascorbic acid. So with them, I'm a little more cautious. Oily sensitive skin, L-ascorbic acid, give it always at night. That would be my dictum. But I do agree with Madhulika, all the derivatives that we give, all of them are SPF boosters. So an SPF of 30 is easily boosted to 40 or 45 if you're using a topical vitamin C serum. So I think, again, picking and choosing patients is the way forward. I don't think there's a dignified answer for that.
I'm going to ask you something as well, Aseem. I have another question for you. So we're going to play role reversal here.
We are co-moderators.
Yes. So have you noticed if you prescribe vitamin C in acne prone skin, a few patients do get an increase in the frequency of breakouts?
That is why I said in oily and sensitive skin, you do seem to have breakouts. Now, early on, what research used to say was that it's because of the irritation potential of the creams or because of the occlusive nature of the serums. But you've seen how thin serums are. I don't think serums can actually occlude anything. That's what I've come to realize, most of them. But what also happens is the system of purging, where if a serum is very strong, it will accelerate the exfoliative properties of the skin, therefore causing purging, therefore causing breakout. So that is my rationale behind it. There is no published data on this. There is no information on this, but this is something which I've told myself. This is the only way I can explain it to myself scientifically.
Yes, one more thing, what I think is that since vitamin C has quite low pH, if it's used alone, like for example, L-ascorbic acid has a pH of 3, and we know that for acne, the acid mantle has to be intact. If the acid mantle is broken, that can also lead to inflammation because of the reduced pH. So I think that could be one another thing. If somebody, for example, already has acne and if there's already inflammation going on in the skin, so on breaking the acid barrier by the decreased pH of the vitamin C, that could also be responsible for the, I think, purging that happens with vitamin C.
True. I think that does play a big role. I had thought of the same thing as well, but then I realized we give glycolic acid. All our alpha hydroxy acids and beta hydroxy acids are all low pH acids. So what happens there? Why don't those cause as much? I know salicylic 2% can really irritate anybody's skin, but even a 1% should. Even a 0.5 salicylic in a face wash should irritate if the acid mantle is being disrupted. So I mean, just throwing it out there.
A lot of unanswered questions.
Yes, but I think good quality, why the good quality salicylic acid, and from what I've read, the good quality salicylic acid and AHA, BHAs have been neutralized by adding other...
pH neutralized, yes. Correct.
That's why, for example, there are certain products which I don't want to name that are very cheap, that are available in Nepal. It's so popular, but each and every product of those that contain salicylic acid as a face wash purges somebody very badly, and I see red inflammation on their face when they come. So I think it's about the pH balance that happens. I don't know.
So, no, I know there's so many unanswered questions that are going to go on here. It's a field where research keeps happening every day. Maybe tomorrow morning we'll have a paper on this, or maybe we'll publish it one day. But as of now, these are the only answers we have. So, Smriti, I think you wonderfully covered antioxidants, the orals especially. So, free radical scavenging and a lot of, not only in aging, but since all three of us do share a common passion in hair as well, extracellular matrix upkeep is one of the main things in any pathogenic mechanism. So your matrix metalloproteinases have really come into the foray, right from aging to alopecias to acne to so many different disorders. But Smriti, tell me honestly, out of all the gambit of antioxidants that you have, we have polyphenols like resveratrol, we have glutathione, the good old glutathione used as an antioxidant. We have xanthine derivatives. We already have astaxanthin, and we might be getting another one, soon. We have carotenoids, which have been around for decades now. Polypodium leucotomus, unfortunately, in India has come into some sort of a battle with DCGI and FSAI. So we don't have any polypodium formulations openly available. We do have them, but not in the open market. But which is your personal choice? If you had to give one antioxidant to a patient for anti-aging, which one would you choose?
I think it's a difficult question in the first place because each one has their own advantages and disadvantages. For example, glutathione, I would personally like glutathione because it is there in every cell. It is the most important antioxidant present in the cell, but it also has problems of bioavailability, toxicity to liver, kidney, and each individual reacts differently to glutathione. So because of that, I think glutathione is the one, if you talk about the ones that are written here. Besides that, my preference would be vitamin C, because that's the one that has most consistently been, proven both in topical and in tablet form. We know that the tablet form of vitamin C doesn't reach the skin as much as a topical form would, but as an overall antioxidant, if you're talking about overall antioxidant capacity, vitamin C as a tablet would also be a good antioxidant. And I usually give combination of glutathione and vitamin C together because both don't have very good bioavailability when given alone. So vitamin C would help improve the penetration of glutathione. So it depends. I think, again, is patient dependent. For example, somebody comes with a lot of tanning, lots of darkening, and somebody's looking for glow, then glutathione and vitamin C in that particular person would be helpful, more helpful than any other mentioned here. But if somebody has otherwise normal skin and there's no issues with the tone, and somebody's just looking for anti-aging, wrinkling, and dehydration and all that, then carotenes and even resveratrol compositions that contain fish oil, resveratrol compositions that contain CoQ10 would help, I think. So it's a combination. There will become a time, from what I believe, there will come a time when the combination of these will be used. I'm so sorry for interrupting. I'm sorry.
Oh, no, please don't worry about that. In fact, I should tell you, there are combinations now that we have in India that have glutathione plus resveratrol plus astaxanthin plus alpha lipoic acid, which is another one which we probably missed, plus CoQ10. I don't know how much it will work and how they are stabilized with each other, how much they interact with each other. But I do believe when you say that we should have things working at all levels, something at the cellular level, something which works at the level of the skin, something which targets more melanocytes, something for keratinocytes, maybe one day we'll have a clear winner. But as of now, we do have to resort to combinations. Madhulika, do you have anything else which you want to add to antioxidants?
Before I answer, I want to ask you a question, and Dr. Smriti as well. So if you're starting with oral antioxidants, right, what is the end to it? How long will you keep giving? Because aging is not going to stop, right? So you're just increasing the financial burden on the patient, because antioxidants are not cheap, right? So will you always include antioxidants in all your anti-aging prescriptions, or you're going to focus more on your topical anti-aging modalities that you have?
Okay, Smriti, do you want to answer that first?
I think Dr. Madhulika is right about the budget and then the duration, since anti-aging is a continuous pursuit. There's no end to it. So yes, I would prefer to use topicals first, but then when somebody inquires about it, then only I give other oral forms of antioxidant. Till now, I've never given antioxidant routinely as a tablet form in everyone.
Yeah, same here. Actually, I wouldn't offhand prescribe an antioxidant unless the patient specifically demands it or asks for it, or it is somebody who is, has a photodermatitis where I know they're going to actually play another role in protecting the skin.
True.
But yes, that is my opinion.
So great. I think that's a great thought. And, vitamin C is cheap. So that is one thing which still is cheap, I should say. Some formulations of vitamin C are still cheap. I think I'll put it that way. But yes, something like alpha lipoic acid, I remember we used to give it, as a hepatoprotectant, or even oral silimarine, like we were discussing the other day. But as soon as the derma market picks them up, they become ridiculously expensive. I think that's happened. All of us will agree. Finasteride 5 milligrams is cheaper than 1 milligram. I think We don't need to go forward with anything else.
It's probably economical and cheaper to ask the patients just to have a rich antioxidant diet. Include your veggies and brightly colored fruits and berries and stuff. So, from that point of view, yeah, I think diet plays an important role in anti-aging as well.
So great. I think we should have one more, session on diet as well. I do have a couple of slides. Don't be very happy. We still have about 10 or 15 minutes to go. But we had an audience question, in fact, a couple of them. Okay, Dr. Bhumika is asking, which moisturizers and sunscreens do you prefer for oily skin and dry skin? So Madhulika, if you can take oily skin, and Smriti, you can take dry skin.
So oily skin, I generally prefer any sunscreen which is either in a lotion or a gel form, so as to not give that extra creamy or oil-based layer onto the skin. Something which probably is not too sticky, and make sure the patient is counseled properly as to the frequency of application, the amount to be applied, and how to layer it with the other products that you're giving. As far as moisturizer is concerned, again, something which is very, very light on the skin, again, preferably a gel or a lotion form here.
Great answers. Just to add up to what you said, a lot of these Hydra versions are available now, like, very thin, very light moisturizers. So usually it's a good idea to start people on those moisturizers and then take it forward. But do assess, there are a lot of patients in whom we, again, Smriti, not to increase the financial burden, but some patients who have combination skin, they find a thin moisturizer not very, it's not very effective after 6 hours. And a heavier one will just feel very heavy, especially on the T-zone. So a lighter moisturizer in the morning and a heavy one at night is something I do quite often. We have cheap enough brands to kind of, fulfill both those areas. Just wanted to add that there.
Yeah,
but
and
dry
also,
skin,
yeah,
yes,
sorry
please.
to interrupt, but see, if you're considering a acne prone skin or a oily skin, once that skin is put on treatment, say with retinoids, it no longer behaves or stays that way. So, things may progressively change as go through your therapy and treatment, which may warrant you changing your, formulation in that scenario.
True, absolutely. Smriti, I always find dry skin a bigger challenge to treat than oily skin. We are great with treating oily skin, but dry skin recommendations from your side. Oh, yes, absolutely.
I am
Sunscreens and
somebody
moisturizers.
Severely dry skin all my life. I used to put Vaseline on my face, Vaseline petrolatum jelly throughout my life. So I find treating dry skin easier because dry skin usually doesn't react or explode. There are no purging, no issues with. The concern with dry skin is the barrier. So if you play with the barrier, then we are done. Otherwise, I find dry skin relatively safer to treat. But I think that's our personal opinions. And for dry skin, I'd rather go ahead with moisturizers that contain oat or something soothing moisturizers that contain oat-based moisturizer or pH balanced moisturizer that doesn't play with the skin barrier. And I'd also go with, there are lots of options with sunscreen right now. We can go for superfluids. There are so many superfluid sunscreens that are to use in most of the skin types. So we can either choose superfluids, or if somebody has disturbed barrier, I also give silicone-based sunscreens to those, especially if I'm sure that they won't purge with that silicone. Then those silicone-based sunscreen for the skin barrier protection. And there are very thick, ointment-based type sunscreens as well. There are some very thick sunscreens. So depending on the skin type, whether it's actually dry or if it's combination, as you said, for combination, I do what you have done. So for dry skin, I'd stick to thicker based products.
I think that's a great answer. And you also, I in fact had a slide on sunscreens, but I think we can skip that now because you've mentioned about the fluid ones. You've mentioned about, lotions, gels, creams, we all know were available. We have sprays as well. We now have specific body lotions, which are, end up being a little more cost effective than the ones. If you look at spectrums, we have broad spectrum. We already had, combination sunscreens, but now broad spectrum has a whole new meaning because we have visible light, infrared, anti-pollution, even blue light. We have many, many things now. We don't know how much of it is actually affecting us, but, a couple of papers here and there, and people are very finicky about skincare. So, bam, we have a new product in the market. But, we do have to sit and analyze as to whether we do need all these things or not. But yes, the options are unlimited here. Since we were on sunscreens, there's a very interesting question by Dr. Divya. She's asked, do we have any sunscreens in India which are board certified? So I'm sure all of you are aware of the error in, authenticating SPF ratings. So a lot of companies that claim 50 or 55 might actually only be 35 or 40. Not that we'll ever get to know, but is any of you aware of any board certified sunscreens? I just, because I'm not, I personally am not aware of any certified sunscreens where the SPF matches, but I'm sure the big brands, the MNCs, at least those brands you can definitely rely on. That's my take. But any of you, if you have any knowledge about this.
I don't think as a country we have a board which certifies sunscreens. It's
No,
only
we have FDA, Madhulika.
I'm not aware. About
not functional is a different
certifying sunscreens. I'm not talking about trial data which evaluates your efficacy and safety. Right? When it comes to SPF monitoring, I don't know.
Even I don't think we have it in India, but it was a big chaos. I think a couple of years back, a lot of American dermatologists came out with a lot of videos on how there is an SPF mismatch. And that is when this whole concept of benzene in sunscreens causing cancer also came up. So yeah, a lot of flack, a lot of articles now which say that sunscreens are actually not required at all. So we have, things which are happening. We'll get to know soon what is right and what is not. But anyways, we will try to look for an answer for that, Dr. Divya, because none of us have a dignified answer to that. Topical glutathione, any effectivity from you? I will answer this last. And both of you know my answer.
So I feel glutathione as an oral antioxidant, again with the limited bioavailability, I would still prefer to probably give it orally, but never topically, because I think it doesn't really penetrate that well. And I haven't, in my experience, seen any good benefits out of it. So no for me.
Smriti, what about you? Any area where you've seen benefits,
Yes.
any type of pigmentation? Yes, please.
We do see benefits if it's given with other products. Like I think I also don't doubt the efficacy of topical glutathione, because I think there's a problem with penetration itself. And whichever products which I've seen that have worked as glutathione in Nepal are usually combination products, and there are other things as well along with that, which probably were the ones that helped with the improvement.
Agreed. I think I mimic both your answers. I do not feel topical glutathione works, not even as a peel, mind you. Unless it's combined with other things, then it definitely works. So somebody has asked, any home care product post peel? And we have a lot of questions, by the way. I should inform you guys. A lot of comments coming in.
Yes.
So, Smriti, any home care products post peel? Or what do you give post peel? What are your favorite products post peel?
Okay, post peel, sometimes I don't give it in everyone, but sometimes we do give topical hydrocortisone if somebody has any kind of irritation or redness during the peel. Some people have more reactive skin, sensitive skin. It's not always predictable. On those cases, I do that. Otherwise, I just ask them to cleanse their face with water, which could be too traditional, but then I ask them to cleanse their face with water and use moisturizer, good emollient moisturizer at night. And in the morning, sunscreen. That's it. That's what I give. But in some people, if in certain cases, I also let them use masks, some kind of good hydrating mask. There's a good mask by one international brand. I don't think I should name the brands here, but there are good thick sheet mask that will help with the repair. So if the peeling is mild, I will give a sheet mask as well.
I think that's a great answer. So a topical steroid, mid to low potency, if required, on a case-to-case basis, a good moisturizer for sure, sunscreen for sure, no actives during that time. And if you're using a cleanser, a gentle hydrating cleanser. So I call them daily cleansers or hydrating cleansers or very gentle cleansers. So those definitely should be used alongside. Dr. Divya has asked another interesting question. Any foods to boost collagen? Either panelist.
Wondrous?
Any foods to boost collagen? Yes, please, Smriti. You also have a lot of research on diet, so why not?
Please, Dr. Madhulika.
Madhulika.
I don't I don't know to what extent foods will boost collagen. However, there are a few studies and reports which say the intake of proteins, including fish and meat-based proteins, do improve the collagen production, along with, say, green leafy vegetables and berries as well. But to what extent are they actually helpful? Because we've been having these foodstuffs all our lives. We shouldn't be aging at all then. So yeah, there is a big question mark, when it comes to that.
I'd like to add some foods, like for example, soy. Soy has been in the traditional food for Chinese and Koreans for all their lives. So I've lived in China for a year. So I used to see people really following soy milk a lot. So although soy could be causing irritation and some form of gastric upset in some people who have allergies or something related to soy. Otherwise, I think the molecule that we talked about today is also derived from soy, the estrogen molecule. So
exactly.
soy to an extent, and bone broth, which has quite good retrospective evidence. It doesn't, I don't think there are any researches on bone broth, but there are many retrospective evidences of people consuming bone broth on a regular basis, having that contains collagen, and that helps to, that's why the skin in the Asians or in those of Koreans are better than those of whites. That's one of the, I think, theories. And some foods that contain antioxidants and vitamins such as broccoli, that's what I tell my patients. So broccoli, cabbages, which are highly rich in vitamins, as well as in I think rather than collagen, we should focus right now on vitamins, because each
antioxidants
other
and vitamins
have vitamin deficiencies. Every second person that I do a blood test on are deficient on multiple vitamins. That's also happening because of the reduced content of vitamin in the soil itself. I'm sure we all know that the soil content of the mineral content of soil has decreased dramatically in last 50 years. It's less than 50% than that was there in the past 50 years ago. Like in 1950s to now, the content of certain minerals have literally declined, and in developed world they are fortifying the soil. They are doing biofortification of the soil to improve the mineral content of the soil. In our subcontinent, that hasn't happened yet in large mass scale. So I think we should focus on food base, on the food counterpart. We should focus on minerals, because we know that zinc is a cofactor, copper is a cofactor, calcium is a cofactor. Each and every vitamin and each and every micronutrient is a cofactor in collagen synthesis, as well as in skin hydration, as well as improving the what do you call that, the interface in the gut, the gut interface. It also helps in improving the reducing inflammation and improving the gut interface, in improving absorption of the food that we take. So I think I would focus more on vitamins than just to look for food that specifically boosts the collagen.
I think great answer. And when you were talking, I remembered there was this, we're called, we are an overfed right now. We're overfed
hidden
and
hunger.
we overeat. Yeah, but we have a definitive hidden hunger. So I love that quote, undernourished yet overfed, something like that. So that's, definitely the agrarian decline is real, not only from India, but this was an article, I think, published in the BJD also some years ago. Now all across the world, the addition of pesticides, but chalo, we'll keep that for a separate webinar. Otherwise, I think we'll go off the hook. So I think Dr. Harvinder Singh is saying sunscreens having PA+++ should be preferred over PA++. I think most definitely, just like SPF, we are an SPF crazy country. But in the West, actually, they pay more attention to PA+ rating or a boot star rating, more to the UVA than the UVB component. So I think, yes, you're absolutely right. Are micro peeling products beneficial? Definitely. We spoke about retinols. We will, in fact, have another slide there. So they do have benefit depending on what you're using it for. IV glutathione, I think I'll answer that for the both of you. So we are not very fond of it. I don't prophesize it at all. I don't like it. Glutathione should be reserved as an oral booster, as an oral antioxidant, and that's what it should be, because IV still does not have, no matter how much published data we have, we don't have clearance for it. Any infusion reaction to glutathione IV in your clinic, and that could be the end of your career. So choose it wisely. I'm not saying don't give it, but give it with all the precautions that you can take. Legal precautions, I meant. Okay, how much percentage of vitamin C is absorbed by the skin topically? So do any of you want to answer this question?
If we see data, they say around 10%, 5 to 10%.
So from a 20%, they say around 10%, and that is L-ascorbic acid, the pure one. From derivatives, they say it's a 1/3 rule. So if you're using a 25%, you're going to get 12.5% of vitamin C, which is finally going to hit the skin, when the derivative is on the skin. Okay, what is the best way to look after a purging skin? If the purging is too much, you stop the product for some time, or you use a lower concentration. If the purging is manageable, upgrade the sunscreen, give a creamier moisturizer at night, and you'll be good to go. The purging period ends within 28 to 30 days, if it is purging and not a fresh breakout. So we are done with questions for now. There are more coming in, but I see we've discussed about retinols, but a quick, just a quick recommendation from both of you. Do you like retinols, retinaldehydes, or pure retinoids? Both of you. If given a choice, which one would you use?
Go ahead, Dr. Smriti.
Okay, thank you. I think it again depends on the age and depends on the indication. If somebody has active acne, lots of oily skin, I would be happier with the traditional retinoid, because that's much more powerful than any retinol or even retinaldehyde. And if you're looking for anti-aging also, I think a retinoid would has a more strong evidence on the anti-aging capacity and the collagen synthesis capacity. So from what I remember from our own textbook of Rooks, I remember that retinoid can improve, has the capacity to improve collagen synthesis by up to 80% in 2 years, which struck me quite hard when I read it for the first time when I was quite young. So I think if somebody is looking for anti-aging and if somebody has a skin that can tolerate a retinoid, I would always prefer a retinoid. But if somebody has come for the first time and it's in a very young age and they just want to add retinol to the skincare and we just want some textural change or balance in the skin, then I would go ahead with retinols. Going to retinaldehyde, I think there are very few retinaldehyde compounds available, like the ordinary and all that. So in theory, retinaldehyde definitely has a less step in converging into a retinoid. But since there are not many, I don't have good experience on retinaldehyde. Thank you.
True. I think the only reason why retinaldehyde came into the foray was the quick onset of action as opposed to the other ones, because it's a step less, like you rightly mentioned. But yes, there are lots more now, hydrated retinols and granactive retinols, which we won't discuss today. But yes, if given a choice, even I would give a retinoid. But if not, then retinols are a good alternative for sure. It's definitely better.
A lot of people of late prescribing even tazarotene,
exactly.
When it comes
So
to anti-aging.
Yes.
Right. So yeah, the preference would definitely be a retinoid over a retinol when you're trying to correct, when you're trying to prevent, probably. I think a retinol will be a feasible choice.
Correct. Agreed with you. Tazarotene is actually a wonderful molecule. If used 2 to 3 times a week for anti-aging, it's a brilliant, very, very potent anti-aging molecule. So now that we've heard everything, let's try to position topical estrogen. And this will be the last slide. I'll skip the rest of the slides because we've covered them in the Q&A. So Rudyard Kipling, famous author, kept 6 honest serving men. What, why, how, when, and where? So these are exactly the questions I'm going to pose to you. What will you use topical estrogen for? What are the indications you would use it in?
So I've already spoken about topical estrogen in the form of genistein in my talk right now, where it not only helps as an antioxidant, but it does have hydrating properties as well. It blocks the MMP production, thus reducing your collagen degradation as well. So it does, it acts like a good substitute in postmenopausal women, where there is a clear-cut estrogen deficiency, which is going to eventually progress and hamper the skin. So yeah, that is the answer to your what.
Okay, Smriti, the why. Why would you use topical estrogen?
As Dr. Madhulika has already discussed in elaboration in the beginning of the presentation. So topical estrogen, I think if you look at data, the data looks quite promising and there have been lots of research been done since last 20 years already. But then again, because of the problems of bioavailability and then because of problem of the penetration into the skin, there's a very limited data on how much effective in how many percentage of people it would be. But if we have to at all use it, we'd use it in people with postmenopausal or perimenopausal age who have dull skin, any kind of hydration issues, wrinkling and all that.
Great answer. Madhulika, how would you use it?
So now we are at present aware of topical estrogen as a topic, as a preparation, right? But topical estrogen has been there since quite a while, however, not for the indication that we're talking about today. So yes, I will use it in the topical form, probably as a part of my PM routine, and prescribe, give it like a 3 to 6 months to evaluate the kind of changes it is bringing before I choose to either add another active to the regime or stick with the topical estrogen.
So great, and thank you for reminding us. I think the gel was called Premarin or Cerviprime, which was used for
there cervical is Avalon cream as well.
Avalon as well. No conflicts of interest, obviously. We're all dermats here. Yes, we do not practice gynecology.
Yeah, but we've been using those for entirely different indications. So
agreed. So Smriti, when would you use it? Now Madhulika mentioned menopausal and postmenopausal women, but any specific indication where you feel you want to use it, or any specific subset of patients you want to use it for?
Yes, I think from what I've been reading on it, I've never used it as a skincare routine till now because it's not available in Nepal. I'm really looking forward to the product that's been launched, that's going to be launched pretty soon. Otherwise, I've never used it for skin.
Yes.
Oh wow!
Sorry, please continue.
That's
please
nice.
Continue.
Yes, no, that's nice. So in Nepal, we've just had certain estrogen creams that we've used for dryness, vaginal itching, and all that. But for on the skin, I've it. But since looking at the data, I'm really looking forward to using it in people with. I would start with people in postmenopausal age group who have dehydration, irritation, dullness, and wrinkles and all that.
Perfect. Madhulika, where would you use it? Obviously, anti-aging the face is a given. Any other body parts you're interested to see the action, or where you feel we can probably, do a study or probably use it,
So
position it?
obviously the face is the most obvious indication, but it is worth giving a try on the neck area, on the back of the hands, which are more prone to aging after, say post menopause. So yeah, it is worth trying, and you're doing a small study or a small trial on these other indications as well.
So great. And one very interesting thing you brought out in your slides was that estrogen dependent skin and non-estrogen dependent. So the face actually, and this I was very startled to know, I learned this today itself when I was preparing for this presentation, that the face has more number of estrogen receptors than the breast and even the genital area. So that's quite a big revelation for me. So the face has the highest number of estrogen receptors in the body. That's quite a big thing. And moving back, is it scientific? I think we've proven it today. There is enough science here, not enough enough evidence, but not enough how can we put it, we don't have any real world data on this, but there is definite data on paper. So treatment of skin aging with topical estrogens, this was a clinical trial published in the International Journal of Dermatology. All of you know those are very difficult to come by. This is a study from JAMA is again a journal which will not take a sponsored study, or these are journals of very high repute. Induction of collagen by topical estradiol, and they did a split study between sun-protected and photodamaged skin. So they used it on both types of skin. And since we were commemorating Women's Day a few days ago, and I am with two beautiful women here today, the International Journal of Women's Dermatology, Estrogen-Dependent Skin. This is a lovely article if any of you want to go through it. It's a systematic review, a very beautifully done article. And we've discussed topical estrogen, with genistein, the soy isoflavones. Uplevity was discussed by Dr. Madhulika with acyl tetrapeptide 4, low molecular weight hyaluronic acid. And we've all realized today that these are not simple additives, but actives in themselves. So it's a great combination together. Sunscreens we've spoken about. Final pearls of wisdom from Dr. Smriti and Dr. Madhulika, while I quickly check if there are any more questions.
Yes, Dr. Madhulika.
Okay, so today we have gone through, or we've kind of familiarized ourselves with a lot of different molecules, and we will definitely feel more comfortable, confident once we start prescribing them and seeing the results from them. So it's more about experience based over evidence based, because the evidence in the form of literature and data is still very limited. So I would urge all of you to give it a try. Let us kind of pool our data together, learn from each other, and see how far these molecules take us off the paper as well.
Great.
Yes.
Smriti?
Yes, thank you so much. I totally agree with Dr. Madhulika, and I was also not aware about the so many studies that were already there on topical estrogen. I didn't know about that before I was lucky enough to participate with you guys today here. So I'm quite looking forward to the results that these products are gonna bring, and I think the post-menopause or menopause is itself quite agonizing for women. It's such a big in their life, and it leads to as much as I read somewhere that there is as much as 30% collagen loss within 5 years of menopause, which is quite scary for us all women. So I think this will open a new horizon to a new arena where we can really try to limit the damage that menopause would cause to women without having to worry about the hormone replacement therapy, without having to worry about the side effects that a hormone replacement therapy would actually cause in some women. So I'm quite looking forward to the product. Thank you so much.
Thank you. I think we mimic each other today. There's one question which I really want to take up. Estrogen and cancer. I like that question. That's by Dr. Archana. The reason why that's important is because we know even when it comes to combined oral contraceptive pills, the reason for that combination is not because progesterones have a mild anti-androgenic effect. We all know the main anti-androgens there are estrogens, but to avoid an unopposed flow of estrogen is the reason why we add progesterone to a combined pill. So topical estrogen, do you think, obviously penetration, concentration, a lot of studies will have to be done there are no case reports on an association as of now, but do you think that could pose a problem in future, maybe on a larger surface area, or just throwing it out there? Do you feel that could prove to be an issue? Or Madhulika, you can go first. Or Smriti, you can go. Yes, yes.
So sorry. I think that's something only time will tell. Even when, like, we know about parabens, right? There's so much of thing going on about parabens, and even after years and years of use, we found out that paraben could alter the HER2 receptor in the breast in some people who are prone to develop breast cancer. So this is something that we cannot tell as of now already. But then that is, I think, a possibility. Again, depends on the genetics and the risk factors.
Agreed.
I agree with what Dr. Smriti has said. Eventually, like even something as simple as tacrolimus, which we prescribe day in, day out, has a black box warning. That doesn't kind of scare us into prescribing it. So yeah, only time will tell. Probably we need more evidence and more research as far as how much the systemic absorption of this topical estrogen is and what its effects could be.
Great. So I think we've come to the end of today's presentation. We're already 34 minutes ahead, beyond time, sorry. So aging is a complex multifactorial process. Combination therapies are the order of the day. There should be no doubt about that. Topical estrogen, while it's very strong on paper, we should be able to see if it is as effective in real world data as it is efficacious on clinical studies. The only way that will come through is with pooled data, positioning the molecule more and using it more and more. With that, we've already taken audience questions. There are no fresh ones. I thank the audience for a patient hearing, and a big thank you to Udama Laboratories for this wonderful molecule and today's presentation. Back to you, Mr. Maurya.
Thank you very much, sir. And thank you all delegates, our speaker, moderator, and Dr. Smriti Shreshtha for giving us this opportunity and talking on this new molecule. I'm really thankful to all the participants also. Thank you. Thank you, doctor.
Thank you for having us.
Thank you and happy Holi.
Same to you. Happy Holi to you.
Happy Holi in advance.
Happy Holi to all.
Bye.
Bye-bye. See you all.
Thank you, everyone. Good night. Take care.
Thank you, sir.
Thank you,
ma'am.
Vinod. Thank you.
Yeah.
Thank you, Dr. Swati.
Thank you, Mr. Shiv Shankar Maurya. It was a wonderful session I was listening to. So we will end the session here. Thank you all for joining. Stay connected.
Yes.
Thank you, Swati. Dr. Swati, ma'am. Thank you for your support.
Thank you so much.